My talk today is going to be about our hypoplastic left heart syndrome experience with the Norwood procedure. The Society of Thoracic Surgeon Congenital Heart Surgery nomenclature describe hypoplastic left heart syndrome basically by having a slit-like left ventricle, mitral atresia, an aortic atresia, and a hypoplastic ascending aorta and an aortic arch with an ASD that could be large or small depending on the situation. The description of this complex congenital heart problem started in 1952, and the name of hypoplastic left heart syndrome was introduced by Noonan and Nadis. The whole issue, all of those babies born with hypoplastic left heart syndrome used to die within the first month of life. The PDA closes, and you don't have systemic circulation. The baby goes into cardiogenic shock and they die. So prostaglandin did make a difference in the outcome, but what really made a difference on the long term is the palliation type of surgery that was introduced by Dr. William Norwood in 1983. This is Dr. Norwood, me and Dr. Shahata. Dr. Shahata was supposed to be the chairman of this session. We met him in Boston in 2017. Dr. Norwood passed away in December 2020. The incidence of hypoplastic left heart syndrome in the world literature is 0.2 per 1,000 live birth, and it accounts of about 2.5% of the congenital heart problems. 95% of the babies will die within the first month. It do have a little bit of a male preference, 1.5 to 1. In Saudi Arabia, there is 2 papers that was published looking at the incidence and prevalence of congenital heart problem, and it shows that the incidence of hypoplastic left heart syndrome in the kingdom goes between 0.2 to 0.5. It is commonly associated with Down syndrome, consanguinity, and diabetic mothers. In the Gulf area, the Center for Arab Genomic Studies here in Dubai showed that the incidence of hypoplastic left heart syndrome in the United Arab Emirates is 0.21 per 1,000 live birth. And in Oman, they looked at 10-year period at the Nizwa hospital where they have looked at almost 20,000 birth, and 4 children had hypoplastic left heart syndrome. So the incidence is around 0.2 per 1,000 live birth. Anatomy we have described before. It comes at different sort of a variety, from a complete atresia of the mitral valve to a stenotic mitral valve to a borderline left ventricle. And what's going to make a difference in describing or labeling this patient as a hypoplastic left heart syndrome is intraoperatively, where you able to do a biventricular repair or you end up doing a Norwood procedure. What is the causes of hypoplastic left heart syndrome? A lot of studies being published. Nobody knows exactly. Is it an intrauterine infarction? Is it an infection, LV cardiomyopathy? Is it an anatomical problem with the atrial septal defect where the flow to the left side was diminished and hypoplasia happened? Or the presence of endofibroelastosis? We do have seen quite evident the abnormalities in the mitral valve, like a parachute or an arcade mitral valve and a unicuspid or a bicuspid aortic valve. Genetically, still nothing is being identified as the main cause. Majority of our babies are actually normal babies. They don't have a congenital heart problem. But it is associated with Turner-Jacobson syndrome and trisomy. The physiology is all right ventricle is the main ventricle perfusing the pulmonary and the systemic. So any problems with the PDA will cause systemic perfusion issues, and unfortunately this is what we see commonly when they're transferring the babies from a hospital to our center, is they jack up the oxygen, they want to keep the baby supply, so the pulmonary vascular resistance drops, perfusion to the lung increases, and the patient comes in cardiogenic shock. Diagnosis, it is really very important to know the diagnosis in a prenatal period, and prenatal echo is of most important. And it is very clear that if the babies were born far away from a center that deals with hypoplastic left heart syndrome, their mortality goes up. This is, by the way, measured by minutes. When they increase the amount of transfer, the timing takes longer, babies suffer and they die. Again, it's very important to know that patient will do better in a center that they do large volume of such cases. Why the prenatal diagnosis is important? Possibility of fetal intervention, listing for heart transplant if it is feasible in the country you're living at, genetic testing to know if the baby has other genetic disorders, and family counseling for terminating pregnancy and comfort care. Keep in mind, such a disease, we did have a discussion a couple of years ago at one of the Saudi Heart, is it religiously okay to do this? And yes, al-fatwa came that it is okay since the baby has a disease that cannot be completely fixed, لا يرجى برؤه, it's okay to have termination of the pregnancy or comfort care after the baby is delivered. Fetal intervention, still a lot of studies about it, and if it is feasible, and what they do while the baby is in the uterus, they go and they try to dilate the left ventricular outflow tract or enlarge the atrial septal defect. The presentation, if you have a good ductus and it's persistent, baby do okay. The minute the ductus start closing, the baby start having the problem of cardiogenic shock. What is the choice of management till now at this era is the palliative surgery, which is the Norwood procedure, overcome heart transplantation and compassionate care, even in North American studies. Heart transplantation is still not the primary management of hypoplastic left heart syndrome. Majority of the heart transplantation happens if the Norwood fails. 38% happens between stage 2 and 3, the Glenn and the Fontan. 35% between stage 1, the Norwood and the Glenn, and 27% post-Fontan when the Fontan fails. The 1 and 5 and 10 year survival is 82, 68, 59% post-transplantation. The stage Norwood procedure, very quickly, you need to create a large atrial septal defect, do your Damas-K anastomosis between the pulmonary artery and the diminutive ascending aorta, and of course you need to patch all of that. The classical one is where the blalotoxic shunt give you the pulmonary flow, the right ventricular to PA flow, or the Sanu shunt is what is being done nowadays more commonly. This is what we call the hybrid approach, where a balloon atrial septostomy is done to the atrial septal defect. the interventional cardiologist put a stent in the PDA and the surgeon do bilateral PA banding. It seems easy, but it makes stage 2 really very difficult. Quite few number of studies showing that the RV to PA conduit has a better result than the Blalock-Huntosic shunt. Stage 2 is the Glenn shunt. Stage 3 is the Fontan procedure. When you look up the literature of the early mortality of Norwood procedure, it goes up to around 23% between 17% all the way up to 36, 35%. When you look at the STS data, the mortality of the Norwood procedure is around 20%, and majority of the mortality happens in the first month after the Norwood procedure. Mortalities for stage 2 and 3 goes down. The ECMO support was noticed, especially if you do an RV to PA conduit, it's becoming less. A lot of talks about what is the morbidity outcome post Norwood procedure with regards to quality of life, exercise tolerance, and patients do get affected by this single ventricle management. At our hospital, we looked up the referral, electronic referral reports, and it is the 4th commonest diagnosis that was referred to our hospital. And ironically, when Dr. Norwood presented his data many years ago, it was the 4th commonest diagnosis that came to his hospital. It is the 5th commonest procedure that we do in the past 10 years. And when you look at our numbers, till now we have done 267 Norwood procedure. We are leaning towards more Sano-shunt RV to PA conduit, and we do have up to 20-year follow-up and survival. Majority of the patients are nowadays getting the RV to PA conduit because we do believe our results are better with it, and I'll show you that. Our aortic cross clamp time and our pump time is actually less with the RV to PA conduit, keeping in mind that majority of the procedure are done after we do the clamp. You finish your arch, your DMSK, and the RV to PA conduit is done with the clamp off on pump. The only caveat we have noticed with the RV to PA conduit is they are coming earlier for the Glenn shunt. And what we have noticed is the RV to PA proximal connection, muscle get hypertrophied and it becomes stenotic. And this is why nowadays what we use is we use what we call the dunk technique. We put our shunt inside the right ventricle, and that has reduced the obstruction to the RV to PA conduit. We have published in 2017 our intervention post-Norwood, and it is successful with no problems. Part of the intervention done by the interventional cardiologist, from stenting a RICO arc, stenting the PA, stenting the shunt, either a Blalock or a Sano shunt, enlarging an atrial septum that regrew, or collateral coiling. We had to take patient back to the OR for aortic arch repair, for obstruction, and shunt revision when it's not accessible to the interventional cardiologist. This is our sort of overall mortalities. This is 15-year. We're updating our results with the 20-year. Our 15-year survival is 51%. Can I have just 2 more minutes, please? And our results, early mortalities is around, averaging around 25%. Interstage mortalities around 20%. And this is our overall survival. This is the graph showing that our SANU patients do better than BT shunt. And this is the overall survival. A lot of evolution has happened with the management of hypoplastic left heart syndrome. I do hope fetal intervention, stem cell, and surveillance program, which I think played a major part in following up those patients, makes a difference. This is a quick, we're embarking we do feel that the family of a baby having a hypoplastic left heart syndrome suffer a lot. So lately, we're questioning the value of the whole procedure. Is the family, the mom, how they are coping? So what we have introduced is sort of a questionnaire in the value hierarchy for mothers of children with hypoplast. We look at the attributes, the consequence, and the desired end state. At stage 1, when the baby just born, and we talk to them for the Norwood procedure. All of them wants the procedure. This is our religion, what pushes us to do, and we want a healthy child. SubhanAllah, when it becomes a stage 2, they start having guilt. Have I harmed my baby? This is a procedure that I have to bring the baby multiple times to the hospital. There is multiple surgical procedure. So we do not want pain to my baby. No, maybe we have to think about something else. Can I have just, because strange enough, less than a minute. Can I have the slides again, please? Because when you go to stage 3, it's not working. So can I have the next slide? Because when you go to stage 3, no, they go back to stage 1 mentality when they start bonding with the kid longer and they see their loved one after the glen getting better and start to move and walk and start even to go to school. No, please do everything that you could do, and it looks like we are going to have a healthy child. So in conclusion, we do feel a hypoplastic left heart syndrome, even in centers where they don't have heart transplantation, Norwood procedure is a possibility, and we do have long-term survival. Please do not forget the multidisciplinary team. I think it is the most important of having a successful outcome in such complex cases. Thank you very much.